Good afternoon, everyone, and welcome to the PRAPARE Tiger team session. We're going to just let a few more folks join the room, and we'll go ahead and get started.
Hey, can y'all hear me?
Yes.
All right, so I have 2:01 on my phone. So just to be respectful of time, we'll go ahead and get started. For folks who are unmuted, please make sure to mute your line during the presentation this afternoon. Once again, welcome to the PRAPARE Tiger team session. Today we are going to be focusing on supporting health center response to social needs using PRAPARE.
Thanks, Nalani.
Oh, is there any more slides for me to
Oh, no, I'll go ahead and just take over this.
Oh, okay, well, with that, I'll go ahead and hand things over to our presenter this afternoon, Eureka Dela Cruz.
Great, thank you. All right, so did want to acknowledge that this session is supported with funds from CDC and that PRAPARE was developed in collaboration with our partners at AppShow and NOPCA. And so for today's session, it'll be myself. Unfortunately, Chloe is not able to join us today due to a last minute priority, but I'll be here to help provide the presentation for today's session. And so with that, wanted to go over our learning objectives for today's session. We have described the use of PRAPARE of data across different levels of care. We'll also take a look at how to use PRAPARE to respond to social needs and risks. We'll review strategies to develop cross-sector partnerships, and then we'll explore promising practices for closed-loop referrals. So at this point, we actually want to have a moment. We haven't used Menti in a while. We wanted to hear from all of you in terms of what are some of the challenges or barriers that you all encounter when responding to social needs. And then we'll have a second poll in terms of understanding how do you respond to social needs as they are identified. So take a moment to log into Menti. You can use your phone. You can scan the QR code on your phone, or you can go to menti.com and enter the code 5545, and then and yeah, we'll just do the whole code there. So, and I think oh, and Chloe's actually here with us. Okay, great. So after the poll, we'll hand things over to Chloe. So just wanted to provide that quick update. So if folks haven't been able to, definitely join us on Menti, and we'll go ahead and see what the polls are saying. So let me go ahead and go over here. All right, so these are some of the top challenges and barriers that all of you have encountered when responding to social needs. The first one is that resources are not available. There's a lack of local resources, and there's a lack of local resources in the community. These are pretty common ones. We'd love to hear some other challenges that you all have. So far, we've got 3 different responses, but we'd love to hear some more. Another challenge or barrier is avoiding duplication of services. Another one is that patients don't know what to say. That's a really interesting one. I'd really love to hear more about that. So if you want to drop any more detail in the chat, that'd be great. But what are some other challenges? And I'm glad to see that we have some that are resource related and other that is really from the patient perspective. All right, here we have patients are reluctant to answer the phone. The voicemail is full. That is very true. Great, great perspective there. And then we have someone here that has responded within our organization on our behavioral health side. There are staff that do a similar job as myself. They are in a different EHR, so it is hard to know what they have done for the patients. Wow, so that data infrastructure really has played a role in not being able to, the systems don't speak to each other, therefore the staff are not really understanding what you all do together. So that's a really interesting challenge that you've all raised there. The patients don't know what type of health insurance to apply for. That's a really powerful response there, or barrier, because when it comes to insurance types, we know that there's different types that might be beneficial for some of our patients. And so that is something that is very helpful there in terms of being able to understand what their needs are.
Amy.
If everyone can please take a moment to mute themselves, that'd be great. And thank you, Nalani, for dropping in the Menti code. Again, it's 5545-5646. And then here we have some other responses. Patients are embarrassed to admit they need help. From the PCA perspective, they get the sense that the local community resources might be ephemeral in terms of they're always changing, they're starting up, they're fading away, variable levels of reliability. So those are really good different barriers that you've all encountered. And again, lack of local resources. And thanks for those that have dropped into the chat. It's always good, if you can't use Menti, that's okay. We will definitely keep an eye on the chat. So if you go to menti.com, thank you, Nalani. You should be able to join the poll over there. But some others have used the chat to drop in some of their responses. So we have from Sandra, very limited amount of resources to offer to patients. Transportation is another barrier. So those are just some of the different, challenges that you all are encountering. So thank you for that. Shortage of outreach resources. And then we have here tracking if the community resource was actually provided by the EHR. So from the health center perspective, how does that closed loop referral look like? So thank you all for responding to that particular challenge and barrier. At this point, I'll move us on to the next poll. And this one is, how do you respond to social needs that are identified? So again, we know that there are challenges to responding to different social needs. There's different perspectives, data, partnership, resources, even the patient perspective. Those are different considerations that we have to navigate. But when you're able to respond to social needs, how do you respond to them? What are some of the things that you all do in terms of responding to social needs that have been identified within your patient population? And if you're on Menti, you should be able to refresh your browser. That'll take you to the next poll. All right, here we have, so right here, not screening at this time. So if you're using Prepare, you are actually screening for social needs. So maybe you're considering using Prepare, which if you are, you're in the right place. You'll learn more about how to use it. But hopefully when it comes to screening, Prepare does allow us to screen for social needs, right? So I just want to make that very clear for all of you. So here in the chat, we have from Wanda, referrals to community partners, also doing a warm handoff. That's really great. We have some other responses here in Menti that the org is currently still in collecting data phase. That makes a lot of sense. That's great to hear that. Use of referrals sent to a social service coordinator. They network with community resources. That's a great response there. Creating a referral based on their social needs, especially we do not have local resources. Then we also have referring to community-based resources or connecting them with insurance benefits that they may not be aware of. That's a really great one. And then reach out to possible resources in community for additional assistance. Prepare helps with needs. Yes, it does. Thank you. I appreciate you sharing that. And then referring to community resources. So great. I mean, and I know many of you, hopefully you're able to really think about, how you're able to leverage Prepare in your response to social needs. And that's the purpose of today's health center. Today's session is to talk about how to use Prepare for referring out and for addressing those social needs. And then I'm just seeing in the chat here. Okay, thanks, Linda. There's some health centers that have Prepare, but they don't know how to use it. Definitely reach out to our team or to your PCA, and hopefully we can all partner to help you all with the use of Prepare. And then from Erica, completing the assessment and Prepare to ensure that all SDOH are captured, and from there connect and network with appropriate resources. So great. These are wonderful responses. We have another one here. Listening is key. Then clarifying needs versus resources that the person has already tried. Some patients may just need contact info for community resources. Others may need more hand-holding per se. That's really great in terms of really trying to gauge where the patients are at and really seeing what support they might be needing. Okay, great. So at this point, we'll go ahead and go back to our PowerPoint. Thank you all for taking the time to respond to the Mentimeter or dropping your responses in the chat. I will go ahead and bring us back to the slides. And at this point, I think Chloe is on with us today. So I will go ahead and hand things over to her.
Hi, everyone. Thank you, Nalani. Thank you, Eureka, for getting us started. And I will take things over at this moment. We wanted to discuss with you all in terms of setting the stage of why are social determinants of health, and why are social drivers of health important? As the driver of health inequity, social determinants of health have shown they have a greater impact on the population health and individual well-being than factors such as biology, behavior, and medical care. Medical care, although essential to our health, has shown to be relatively a weaker influencer of our health, and that it has been estimated to only account for about 20% of the modifiable contributors to healthy outcomes for our population. There are, the other 80 to 90% have been attributed to the social, economic, and environmental factors referred to as the social drivers of health. All right. And so now this leads us here as to why do we want to collect PRAPARE data on SDOH in terms of why collect standardized data. Health centers and others are increasing their use of social risk screenings, tools such as PRAPARE, to better understand, document, and address the root causes of not just poor health outcomes, but of inequities. Having this data integrated into systems can allow teams internally and externally to collaborate to proactively assess and address client social risk, and it can also be used to guide local partnerships, which we will get into a little bit later, and accelerate alignment. This diagram provides basically examples of use cases of social interventions, the documentation from patient to policy level in alignment with this vision. So this slide illustrates our thinking and our experiencing coming from our prior work and bringing patient-level SDOH screening to scale across health centers. This data can be used for better care delivery and planning from the patient all the way to the system and policy levels. As health centers are increasingly committed to standardized social risk screening, our work can maximize the impact of the data towards building system capacity of health equity and accelerating the alignment strategies that can make that happen. So now, in terms of the use of PRAPARE data, this diagram provides examples of using PRAPARE data from patient to the policy level, and its impact, starting with the individual level that includes patient and family. So in terms of the patient and family, you can address and track PRAPARE needs to improve social care and well-being. Care team members connect patients with clinic community resources, close the loop on social needs, and proactively follow up on internal, external referrals, and so on and so forth in terms of the local level, all the way down to the state and national level. And of course, these slides will be provided for you all, so we encourage you to take a look at them. So in terms of our follow-up, you will be getting a copy of this presentation. Next slide, please. All right, so now let's talk about health equity and the role social interventions play. Social needs and interventions data can be used to advance health equity. This roadmap to health equity outlines how social needs and social intervention data can be used to advance health equity efforts. Taking a closer look at community context, we know that social needs and risk are driven by social and institutional inequities rooted in structural racism and discrimination, and that we have a fragmented care delivery system that is not equipped to address or manage social needs. By understanding patients and communities within the community context, we can begin to understand and document social needs, risks, and interventions, in addition to communicating identify community needs across care, teams, community partners, payers, policymakers, which leads us to care transformation, if we start there. Here we start to see new or improved interventions, community linkages, closed loops, efficient and integrated care decisions and management, and importantly, patients are included, engaged to address their care. The impact we will see is that improved care outcomes, a lower cost, build community capacity to address SDOH, accelerate policy and payment change through social care evidence-based practices, which leads us to achieving our final goal of health equity at the patient, community, state, and national levels to include effective models addressing health inequities and strategies for achieving such health equity. Next slide, please. So now in terms of capacity to respond to SDOH needs, building capacity to address social drivers of health will begins with an assessment of your organization's current capacity. So after we've decided that in terms of addressing social needs and the screening, we have to assess like the capacity to respond to such needs. So again, that requires for you all to begins with the assessment of your organization's current capacity. What resources, some of the questions that you want to think about as you are assessing such resources. What resources does your organization have available to focus on addressing identified needs? And in what context do these resources exist? Are they internal to your organization, or do they exist outside of your organization? Next slide, please. All right. So in terms, we do have a, it's a bit of a click-through animation for you all. This may, you'll see that as we click through, this matrix comes from our chapter 8 of the PRAPARE toolkit, and it offers some recommendations for what to do after you've assessed your organization's current capacity. So after you assess your own resources, it's important to determine what resources exist in your community. Analyzing your setting in terms of the type and extent of resources in your organization and in your community will give you a sense of where to start in bolstering your capacity to address the SDOH needs of your patients. Great. So here the vertical axis represents your organization's internal resources, and the horizontal axis represents the amount of resources there are in your community. For example, if you identify that your organization has fewer resources to respond to your SDOH data and your community has limited resources to address your patient's needs, the bottom left quadrant may offer a starting point for your capacity building. In this case, where you have a few internal as well as fewer external resources, you can build capacity by doing the following: raising awareness to strengthen staff, patient, and partner knowledge of social drivers of health. Each quadrant also offers specific suggestions on how to build capacity for the people, processes, and technology categories. So if we move up directly up along the organizational resource axis, those who locate themselves in the top left quadrant will have more internal resources, but local community resources are still limited. This puts your organization in a position to create in-house services. So if you have staff time or you have highly effective processes or workflows, you can develop services internally that meet your patient's needs. Or you may be in the reverse position where your community has an abundance of resources, but your organization's internal resources are still developing. In the bottom right quadrant, you'll find that partnering with community-based organizations or community leaders can help you act on your SDOH data, even though your organization's internal capacity is still growing. So finally, for those organizations who have both internal resources and many community resources, you can strengthen capacity to act on SDOH data. You are in a good position to form coalitions with community partners and advocate for policy and environmental changes. It's important to know that locating yourself in one of these 4 quadrants that are presented does not mean that you might not also locate your organization in a different quadrant. For example, you might have ample community resources and your technology resources are great, but you're short on staff and on staff time, which would, of course, greatly hinder your capacity to implement services. Or there may be plenty of local community resources, but there are a few or none that specifically address your patient's most pressing needs based on your data. So next slide, please. So now, as I stated earlier, you want to think about why form such partnerships. It's encourage partnering with community-based organizations. In terms of developing cross-sector partnerships, you want to ask why form a partnership. Interventions to address the social risk factors that are impacting your patient's health outcomes can feel daunting, but it is important to remember that you do not have to develop all of your SDOH interventions in-house or do all of this work on your own. Partnering with community-based organizations who have already developed services and programs that address the social needs of your patients can be a great way to get patients' social needs met and lessen the resource burden placed upon your health organization. Furthermore, as more health organizations form cross-sector partnerships with non-clinical organizations outside of the medical setting, our healthcare systems will further increase its abilities to not only manage disease, but address factors that lead to poor health. So a lot of the times we hear that folks are hesitating with starting because they do not have the proper resources to address patients' needs. But it's important that you actually start with the screening because screening will then give you an idea of what it is, what are the needs of your patients, and as well be able to partner up with local organizations. So while healthcare organizations may not always be an expert in addressing social needs, they are well placed to witness the impact of social risk factors that remain unaddressed and are a great gateway to receive and then refer patients to resources to meet their needs. So when you think about your forming these partnerships, you're probably thinking, who should your partners be? So as you expand your efforts to impact social drivers of health, there's a wide world of potential partners to consider. So you want to start with your data. Which social risk factors were most prevalent when you screened your patient population? If there were a handful of issues that rose to the surface, identify community-based organizations that are focused on addressing those needs. It might be a great place to start. So then you want to identify strategic opportunities. Are there well-resourced partners in your community who are looking to serve your patient populations but don't have the relationships or access points that you have to tackle all of these needs on your own? Access points that your clinic offers, Perhaps you can work together. Do not feel that you have to tackle all of these on your own. Alternatively, there might be an under-resourced organization that is already addressing the social drivers you'd like to work on, but could benefit from your financial or staff support. And then you want to go where the resources are. Are you located in a rural area or small town where resources are scarce? Consider reaching out to social service organizations in the next closest city to see if they would be willing to partner with you to serve your community. And finally, let the needs of your population segmentation guide you. If you are working to improve care management for a specific patient subpopulation, i.e. uncontrolled diabetics, consider partnering with external organizations who are also focused on serving this same population or ones that are addressing social risk factors that have an impact on the target population's health outcomes. Slide, please. So this leads us to developing resources with staff and patient input. When developing resources such as community resource guide, that maps to prepare identified assets, risks, and experiences, engage in a wide variety of staff and patients, as they may be knowledgeable about resources available in the community that you or others may not be aware of. So this all goes into building capacity, like accessing your resources. It's important for you to have that relationship with your staff and your patient. Get them included in all of this. So a great way for this is flyers. They are a great way to educate patients and community on the purpose of PRAPARE and how data will be used to inform care and services at your organization that can be placed throughout your organization for patients to see. For organizations that are supporting members and implementing PRAPARE, consider building a website to house resources and training materials, host a shared calendar of events, share results and lessons learned to engage discussions. Next slide, please. So, all right. So how do you form a successful, equitable partnership? When forming a partnership, it is important to consider these key phases through which your partnership happens. It's important at the beginning of forming the partnerships that you clarify the common agenda between the participating organizations and identify clear objectives. Once shared goals or roles and responsibilities have been agreed upon, partners can all sign a memorandum of understanding or an MOU to secure commitment and accountability. Partners can revisit these goals and responsibilities throughout their partnership to ensure that they continue to align. Once partners are committed, they should all collaborate to develop a strategic action plan that helps them achieve their shared goals. As you implement your work together, it is important to regularly check in on the partnership to discuss what is working well, what could be improved, and to evaluate your collective work. This may require sharing data across organizations. Data use agreements can be helpful agreements to safely share data and secure the privacy of the data. Next slide, please. So now, as we talk about partnerships, we know it's not picture perfect. You will run into some barriers and some challenges. So these are some things to consider when forming these partnerships. We know it's not always peaches and cream. So you want, in terms of high front-end investment, forming a partnership often requires a high investment of resources at the onset. So, for example, staff time spent writing grants to secure funding with returns not until later. Consider starting off your partnership by seeking out low-hanging fruit, which requires less effort from partners. An example of this might be sharing informational materials or referring patients to another organization's services. So lack of resources, another challenge or a barrier is lack of resources to support partnerships. Partnerships require an investment of resources from the partner organizations involved. If those resources are unavailable internally and cannot be secured externally, the partnership may fizzle out or see limited success. So be sure to discuss how you'll support your partnership from the onset of the collaboration. So we see a common theme of communication. Getting clarity on resource needs early on can help determine the feasibility of the partnership and may help you decide with whom you should partner. And another barrier is power imbalance among partners. Trust and respect are key ingredients of any partnership. And if there is an imbalance of power amongst partners, it can impact how they feel about each other. So if both or all partners do not have a voice in the partnership, it will suffer. From the onset of each partnership, there should be a clear understanding of how everyone involved will contribute to the collaborative in a meaningful way. Recognition of each partner's contributions will go a long way in creating trust and respect. And finally, we're not saying these are all of these are the only challenges that you'll have, but these are some common ones. So different agendas among partners. It is important that partners maintain clarity and commitment to their shared agenda. A partnership can't succeed if the parties involved aren't on the same page and working to achieve the same outcomes. So honest and clear communication is the key to ensuring everyone is on the same page in a partnership, and that partners have alignment in their expectations and goals for the collaboration. So continue to revisit goals throughout the duration of the partnership to ensure they continue to align. Next slide, please. So now, we've discussed partnership. So now we want to discuss engaging in advocacy work. In some cases, taking steps to address the social drivers of health begins with advocacy. Acting as an advocate and speaking up about the importance of addressing the social, environmental, and economic conditions in which people live, and advocating for the financial support of social resources both within and outside the four walls of your organization. Without such support and resources, it is difficult to develop sustainable and impactful interventions to address the social drivers of health. So to engage in advocacy work, a good starting point is forming relationships with your representatives. But how can you gain access to your local, your elected officials? Think about connecting with them at events or meetings that they attend. So such as town hall meetings, community planning gatherings, or campaign events are a good place to start. You might also connect with professional networks, so your PCAs, your National Association of Community Health Centers, to connect with your elected officials as part of a larger organized concerted effort. Introduce yourself and your organization and invite them to come for a visit or a tour. It's hugely valuable for you to create opportunities for your elected officials to meet your patients and to hear from them and your staff, see the work you do and the work that you would like to do. So, and another thing that you can do is creating effective messages. How do you tell an effective story about the conditions in which your patients live and how those conditions impact their health outcomes? So you want to choose the right messenger, use heroes and villains, focus on action and conflict, use your data that we discussed about collecting earlier, and close with a solution. And finally, some other ways that you can engage in advocacy work, you can find alignment. In your advocacy work, you will encounter audiences, including your own stakeholders, who do not always share your view. It is important to share a clear understanding of what their views are and where they align or differ from your own. There may be good opportunities for working together, even when your views diverge. And knowing their stance can help you tailor your conversation and seek areas of common ground. Next slide, please. So now we discussed forming partnerships and advocacy work, but now it's important to discuss how to act on the data. We discussed why why it is important to collect data. So now we want to discuss how to act on the data. Here we wanted to demonstrate the link between SDOH and SI. SI and what SI data collection is also important. Social interventions, SI social interventions, are important because they're foundational to clinical quality improvement, practice transformation, and addressing SDOH. We have been involved in pilots, research studies, and programs that show that the importance of social interventions for addressing social needs by improving health outcomes, lowering costs, and increasing the likelihood of appropriate care, including preventative visits. And why collect as social interventions in combination with social needs data By collecting social needs, you'll have a comprehensive understanding of the patient's social needs. But if you don't document social interventions that you use to address them, how will we know that the social needs have actually been addressed for patients? Or are there remaining social care gaps that haven't been addressed for particular racial, ethnic populations? When we ask our stakeholders why they want to collect SI data, they say that they want to use the information to increase community capacity to recognize hidden disparities and proactively address SDOH with effective social interventions, especially so they can coordinate this information with community partners to comprehensively address the root causes of health inequities. They also want to use the data to demonstrate their community value and provide necessary evidence to continue to provide critical social interventions so that they can sustain their services for their vulnerable populations. So overall, this data can help social care providers better understand their levels of staffing and resource needs to continue to fund social interventions and the impact these interventions have on healthcare delivery, outcomes, and costs. And an organizational level, the data can also help prioritize services for racial, ethnic populations and allocate limited resources. But ultimately, the data promotes a common language for different sectors to better align on upstream initiatives to advocate for the needed social interventions, changing policies and systems to repair the inequities in our system. So with that, I'm going to pass things along to you, Rico, who will take us through the rest of the presentation.
Thank you so much, Chloe. I appreciate you providing that wealth of information and really just giving us that 3,000-foot view of why we do all this work, right? Why are we using PRAPARE to understand the social needs of our patients? How are we acting on this information? And so really what Chloe really walked us through is the why and a bit of the how in terms of, working with partners and really even engaging in some level of advocacy. Now I'm going to drill a little bit more into, I would say, more detailed or more, relevant activities at your health center in terms of how do we use that data, right? So the first particular data or the first strategy is risk stratification. And really what risk stratification is, it allows us to segment our patients into distinct groups of similar complexity and care needs to better target their care and services. So the reason why we do this is twofold. At the population level, it allows us to create care models that really take into consideration the needs of our population subgroups. So as a health center, as a care organization, we're able to understand this is at the population level, this is what we need. And that really helps us with staffing, right? And then in terms of why we also risk stratify is at the individual level. And this is really where it's powerful in terms of really understanding the level of quote unquote risk that is assigned to each individual, each patient that you care for your patient. The reason I say risk is just and I put it in air quotes, is that we know that a lot of social drivers of health, they're informed by factors outside of a person's control. So we just want to be mindful of how we talk about this, but really at the individual level, it really allows us to customize care for our patients and really zero in on things that will be most meaningful for them. And just also wanted to highlight NAC's Elevate platform, which is hosted by our quality center here at NAC. If you want to learn more about risk stratification, the what, the how, the who, and all of that, definitely encourage you all to look into those resources at the quality center. So in looking at how does this fit within our work as health equity champions, if you will, really wanted to kind of draw our attention to the population health pyramid. And this is a very powerful way to really think about our patients and really think about how do we stratify them, how do we understand their level of need. And really, this pyramid is based off a lot of work, a lot of research that has already taken place. But as a health center or as a health provider, it's really important that we take the time to understand which of our patients fall into the buckets of minimal risk, those that are at rising risk or at risk, so to speak. So folks that are just, they're starting to get to have some indicators in their life that shows that we might need to start paying some attention to them, or they might need something different rather. And then we start going into high risk and very high risk. And so here are two patient examples. They're fictional, if you will, but I'm sure they look familiar to you. First of all, we have Fatima here. She's been, by using PRAPARE, we were able to say that Fatima would be categorized as an at-risk or rising risk patient, right? She's a 55-year-old woman. She was recently diagnosed with type 2 diabetes. She's currently on 3 medications and she works 2 jobs. So this, based on both her medical conditions, but on her social needs and what we were able to assess from using PRAPARE, we realized that Fatima is really at this at-risk level. Then we have Kenji, and he is someone that we've identified as someone with very high risk needs, or as a very high risk patient, if you will. He was a 75-year-old man. He has uncontrolled diabetes. He has 3 chronic conditions. He lives alone. He takes 8 medications. He's had 3 falls in the past year, and he's had 2 hospitalizations as well. So again, based on what we've deemed as different indicators for the different risk groups, this is how we would categorize Kenji, okay? So how does this look like? How does this relate to our health centers or organizations that use PRAPARE? So for the sake of numbers and just for the example, let's say your healthcare organization has a patient population of 10,000 people, right? Out of those 10,000 people, we have 834 individuals that have been identified as having diabetes, okay? Of those 834, there are 223 people that have uncontrolled diabetes, okay? So thinking back to our previous story with Fatima would be considered, she would fall into that general population of someone that has uncontrolled diabetes. She has an A1C that's above a 9. And so because we were able to stratify and identify her risk level, we've been able to see, okay, Fatima, let's work with her and let's support her with the diabetes nurse educator and a community health worker, okay? And then we would also, in working with Fatima, we would have monthly phone calls with her. Either the nurse educator or the CHW would call her or have monthly touch points. And maybe there's an education group for those with diabetes that she could be a part of, right? So at this particular level in segmenting our population, she's part of that group that has diabetes, but she's not considered high risk or needing more services. But let's think back to Kenji, okay? So within this example here, we have the 834 diabetics, okay? 223 of them have uncontrolled diabetes. But out of those 223 individuals that have uncontrolled diabetes, 56 of them have been deemed high risk. And we're going to use Kenji in this particular example, okay? So we see that in this particular example that Kenji, based on his level of need, he would have a nurse care manager. So that's the first difference. Kenji would be supported by a nurse care manager that can really guide him in what his care and treatment would look like. Based on the fact that he has 8 medications, he would also work with a pharmacist that can do some medication reconciliation, but maybe even possibly look at what medications would need to be adjusted, right? We saw that Kenji had several falls, he was hospitalized. So we'd want to make sure that he's also connected with the pharmacist that can help navigate that medication, all the medications that he's taken. And then he would also still have the CHW. In this particular example, the CHW would do home visits, okay? And maybe the nurse care manager, maybe the pharmacist would do that. But in this particular example, knowing that Kenji is isolated, he lives on his own, he needs more support, we would wrap our arms around with Kenji with a little bit more support for him that's meaningful, that would hopefully meet his needs. And by having that difference in terms of a home visit, that's a little bit more intensive. But this would be something that would hopefully work out for him. So just wanted to provide an example of the power and the utility of risk stratification and how you all can take a moment to do that work using your prepared data, right? You have the clinical information in your EHR, then you can have the prepared data. You can then leverage those two sets of information to really understand how would you understand your patients in terms of the risk level, and then assign individuals or assign patients with different care models, right? We know because it's so resource intensive to have 56 patients that would need this level of care, that would also help inform your staffing model as well, and funding. So hopefully this provides some examples, some idea in terms of the power of risk stratification. And if you're not doing it at your health center, definitely reach out to your clinical teams at your health center or at your organization that's using Prepare, and see if you're able to begin that process of doing risk stratification. So as Chloe mentioned earlier before, we had that coin, right? On the one side of the coin, we had the needs data. What's important to understand, what is the level of need that we have in our community? It allows us to really understand what would be, what our response could possibly be, but also what are the things that we could do to respond to that. And so on the other side of that coin is that social interventions. And so here, I wanted to take a moment just to talk a little bit about social interventions. And social interventions, many of you are already doing this work. And really, it's the non-clinical services, what has previously been called as enabling services. And these are the services that address the non-medical health-related social drivers of health. And so when we think about social interventions, it's case management assessment. And after that assessment, then you would figure out, okay, maybe there's some case management, treatment, and facilitation that's needed, kind of like what we did with Kenji and Fatima earlier. Then you would think about another type of intervention would be referrals. So maybe you have someone at your health center or your organization that they would just need some referrals, some information in terms of what resources are available to them. Another type of intervention is financial counseling and eligibility assistance. Then we have health education. Supportive counseling would be another one, right? So if you have behavioral health at your organization or there's some availability in the community, you could refer them out to that as well. Interpretation is a huge social intervention, and definitely want to acknowledge that as a very important strategy that supports our patients. And then outreach. Outreach is another way to support our patients with a lot of social needs. And then finally, we know transportation is something that many individuals will need in terms of being able to access not just their medical care, but really their day-to-day quality of life. These are the things that would help them with that. All right. So on this slide here, I'm going to talk a little bit about what would it look like if we excluded social intervention. And I'm going to present a new patient, Maria. And for this example, wanted to just show the importance and the power of really identifying social needs, but also the documentation or the use of social interventions within our different encounters with patients, right? And encounters is plural for a reason. So Maria is someone that we are seeing at our health center. She has uncontrolled diabetes. She's missed several appointments, and she has poor medication adherence. Her complaint is that she fell asleep at the stove and she almost caused a fire. So she's realizing that she's experiencing some challenges within her day-to-day life. And upon further assessment of Maria, we realized that she also has sleep apnea, she has hypertension, and that really, it's not just that her diabetes is uncontrolled, but she has dangerously high blood sugar levels, right? So then at this point, she's then hospitalized for her blood sugar being so high, and then she's prescribed medication for her hypertension, and then she's also given a CPAP machine to help with her sleep apnea. At this point, 2 weeks later, Maria's back at your health center or at your organization, and she's coming with the same clinical presentation of symptoms. Her sleep apnea, her uncontrolled diabetes, her high blood pressure, all of these things are persisting, right? And this is, again, now this is 2 weeks after she was already seen for these different issues. At this point, the care team discovers that she has not taken her medication or she hasn't used the CPAP machine because she can't afford them, right? So at this point, Maria's gone through all of these different issues. She's gone through all of this, and now she's really experiencing some challenges here. What changes in this next slide is the fact that moving up social intervention screening or doing an SDOH screening like PRAPARE sooner in the encounter with Maria, if we did it sooner with her, we would have uncovered all of these needs, not just her medication, not just understood her medical conditions, but then also understood what are some of the social conditions that are impacting her. This would allow us then to assess, okay, how do we help Maria enroll into public insurance? Let's see what we can do to help her with arranging transportation to a nonprofit for resources. And before we know it, she's able to she's able to take her medication, she's using her CPAP machine, and then she's able to be seen, at the 2-week mark, but now, she hasn't gone through all of these different issues again. So I'm looking at time and I want to be mindful of time. So I'll continue moving us along, but I'll move a little bit quicker. So with social interventions care workflow, this is really the documentation process, and really what the most important thing about social interventions, the workflow and the documentation process is that you're already doing this work. It would be worthwhile investment to actually take the moment to document all of this. And the reason for all of this is that, you want to be able to understand the level of not just need, but the level of resources needed to respond to those needs. So I'm not going to go through each of these. You'll be provided the slides afterwards, but really with the whole picture of doing social interventions, the actual intervention itself, and then documentation, you're able to really understand the level of need and the level of resources that was required in all of this. And so this is just an example of what could be done at your health centers, at your organization, when documenting the different social interventions that have been provided to your patients. So here, as we think about, understanding the importance of documenting the social needs as well as the social interventions of our patients, this really allows us to really take a step back and really understand that, we're really making an impact on the lives of our patients, right? So we see these things emerge. We see that there's an improvement in health and outcomes and lowered costs. Our patients are getting the appropriate care that they need at the time that they need it. They're then able to benefit from social interventions, and then their social needs and their social drivers of health can be addressed. And so what we also see in how does this look like at our health centers or at our organization is a reduction in missed appointments, reduction in ER visits and hospitalizations. We see an improvement in appropriate preventive care. And we see an improvement in quality indicators such as A1C, hypertension, or any other health outcomes that are really important. So really just wanted to provide that big picture view that social interventions, while the documentation may be a bit much, it's the worthwhile investment because it allows you to really track and understand what was needed. And so as you have that needs data and the response data, then you're really able to then plan out and really partner with different funders or partners in the community to address these needs and at your patient population. So here we wanted to share just one example of being able to use this PRAPARE data. Marin Community Clinics administer PRAPARE to patients with uncontrolled diabetes and hypertension, and the patients were referred to MCC's patient navigation team based on their results from the Staying Healthy risk assessments. So MCC piloted PRAPARE at 2 sites within the same community to increase the screening rates. To pilot PRAPARE and to get staff buy-in, MCC wanted to take advantage of value at a time. So patients self-administered or they completed a paper version of PRAPARE while waiting during the wait time in the waiting room. And this saved time from the clinic staff, and then it also added value by making use of the patient's wait time to collect this very important information. And then by having this information, it allowed MCC to begin gathering SDOH data with minimal resources. And the SDOH data was used to create a dual language resource page containing local services. And then it also increased awareness amongst clinic staff about social drivers of health and how they can be a force to bring about health equity through SUH data collection. So we have many case studies on our website, so definitely encourage you all to take a look at that. And so these are just some promising practices in terms of addressing or really responding to social needs of your patients by using PRAPAREs. Again, always start with data. Always think about what are the most prevalent social risk or social needs that are occurring in your patient population, and then think about what are some ways to work with different community-based organizations, CBOs, that are focused on addressing those needs. And here's a great example that there was a health center in Iowa that found that 1 in the 5 patients had transportation needs. And by using the data, the health center performed a partnership with the local and regional transportation authorities to provide bus tokens and taxi vouchers and work on developing more bus routes to areas in need. So that was a really great example of how they were able to use their SUH PRAPARE data. Another example is to identify those strategic opportunities, like Chloe mentioned earlier. You want to see who are the well-resourced partners in your community, and what are some, you want to identify who are well-resourced partners, but then who are under-resourced organizations, because it's important to have both sets of information to understand how all of you can work together, right? And for some partnerships, you might be able to depend on them more. For other partnerships, they might be able to actually benefit from some of your staff in a way that's very strategic, right? Not to add on anything additionally, but to be very strategic in those instances. And then don't be afraid to reach out to organizations to see if you can work together. Again, I'm looking at time, so I'm going to run through these. The other promising practices is to go to where the resources are at, like Chloe mentioned. In this particular example, just wanted to mention that in rural Massachusetts, there was a health center that had used PRAPARE, and they did not have a local food bank. So what they did was they reached out to a food bank in Boston, which was 70 miles away. And because of that partnership, the food bank was able to kind of have a satellite location, if you will, and they were able to then deliver food to that rural area, so that their patients could have some options for food. So that was a great example there. And then this next example is let the needs of your population guide you. So again, like Chloe mentioned earlier, you want to take the time to really understand what information your data is telling you. Do that segmentation, do that risk stratification. It's worthwhile for so many reasons. And then you're able to then really think about how do we have some effective partnerships in our community. And in this particular example, they were able to work with the state chapters of the American Heart Association. And because of that, they leveraged funding that was already available to benefit the patients in the community at the health center with the most needs there. All right. So here, when it comes to really thinking about health equity and really thinking about how does this apply on your day-to-day, really, we know that the resources are limited at your organization. And these are just some very sobering, applications of using PRAPARE. Really understanding that by having this PRAPARE data, we're then able to think more broadly outside the walls of our organization. And so really having that ability to do that population level analysis, to really understand what's happening across different groups in our community, racial, ethnic, even those with different language preferences or priority populations. Really important that we understand what's happening. And then we're able to then determine some benchmarks, or to really understand how do we work with these individuals or these communities or these populations that need something different than what's already being provided. And then this also allows us to understand their staffing and resource needs for SUH interventions. So again, that example of Fatima and Kenji, and knowing that we can't have all the staff in the world. Not every patient is going to be able to have all those different resources, but for those that really need it, how can we make those investments in our staffing and in our resources so that we make sure that they have that? And then finally, just really, again, having this information on the needs data and the social interventions data, it allows you to really say, hey, this is what our health center, this is what our organization has done. This is the impact that we're having in our community, in our health center, in our populations. And these are the differences that we're seeing. These are the improvements. This is the progress, or maybe these are the barriers that persist. It's okay if there are barriers that persist and that things are just not moving the needle. And that's something that our team has heard from many different folks throughout the health center movement, is that health centers and other organizations have become really good at clinical management of our patients. But once you perfect that, sometimes that's not it. It's really the housing, the transportation, the food insecurity, all these other investments that are needed to address the needs of our communities. So that's when it's okay to say we're still stuck. And I want to normalize that so that you don't feel blamed or shamed for being stuck, because really it's something that you can partner with different officials, elected officials like Chloe mentioned earlier, or organizations or partners in your community to really address those needs. So at this point, we'll see if there's any questions. I know we're right over time, and I do apologize. I see that we did have some comments earlier about people using Prepare. So thank you for sharing that. Let's see here. We have a question here. Needs data could be viewed as diagnoses, while SI response data could be seen as treatments or procedures. Are there CPT codes for responses or interventions? I think that's something that our team has worked on in the past, and I think we're just trying to figure out, how to really scale this work up, because I think we have piloted our social interventions work in the past. And so I think it's a matter of just really partnering with different individuals to see what can be done with that on the EHR side. So that's a great question, Colin. From Mary, I saw that sometimes as an outreach and enrollment specialist, our job is to observe when they're applying what is going on in HH and ask questions and as to what else can we assist them with, sometimes even make a referral. So thank you for sharing that, Mary. And thank you for the comment in terms of great presentation. Great. Yeah, we're really appreciative that, all of you were able to stay with us. We do have just a couple announcements, and Chloe did drop these in the chat in terms of we have several surveys, several opportunities coming up. We do have our Tiger Team evaluation. You're here for our Tiger Team today, and we've done a lot of great work this past year, and we'd love to hear your thoughts as to how things have gone this year so that we can plan for next year, so we can continue to provide you all with great content and really address your needs. And then we also know that you are all Prepare users, and so these are for current Prepare users. If you're considering using Prepare, we ask that you don't complete the survey quite yet, but really this is for folks that are using Prepare. We've reimagined this survey, so it's a little bit shorter, and we are going to be using this survey in terms of your Prepare use to then also inform our strategy for next year for 2024. We'd also like to be able to capture what's happening out in the field, and so this will allow us to really get a sense of how you are all using Prepare, the impact that it's making, and then we can start elevating some of those stories as well. Next, our team is hosting a Health Equity Learning Collaborative. It's not specific to Prepare. It's actually more that 30,000-foot view of health equity. So our application is currently open, and the application will close in January 2024. January 26, 2024. So there's the link. I know Chloe dropped that in the chat. And then the next one is, if you're available, we know many folks, have been asking about our post-conference workshop that we did at CHI back in August. We're actually doing this workshop again at the PCA and HCCN conference. It's a separate registration for the conference. The PCA and HCCN conference is limited to those that work at the PCA and HCCN conference. However, you are all still welcome to register specifically for this post-conference workshop. So there's the information for that. Yeah, if there's any other questions, those are it for our announcements. But thank you all for staying with us. I know we're over time. I apologize for that. Just wanted to make sure you all had some good content for you all. But all right. Well, thank you, everyone. Have a great day, and we'll be in touch soon. Take care.